Hello again, I am Stamatia Destounis, and we're going to be discussing the workup of the diagnostic patient. So here we go. We're going to evaluate patients utilizing multimodality breast imaging approach. Whether you have digital mammography or digital breast tomosynthesis and synthetic mammography, we utilize mammography, whatever exact technology that we have. We also utilize breast ultrasound and breast MRI, and we're able to biopsy whatever lesion we identify, whether on mammography or tomosynthesis or ultrasound or MRI under the modality that we've identified it. So the sequence of whatever imaging protocol that we're going to be utilizing depends on the patient's age, obviously, and also the clinical and imaging factors. When we have patients that are adolescents, let's say, most of the breast masses that we're going to identify are benign. They may be the breast spot in pubertal children. That may be the first sign of puberty. If you have a prepubertal child, it actually may be precocious puberty or premature phalange. So the development of the breast tissue may be asymmetric, and the patients may come in feeling a lump, or their parent felt a lump, or their physician, but it may actually be the breast bud, or it may be that they have asymmetric breast development. One breast may be larger than the other. So we usually will start with ultrasound for these young patients. Most of the common problems in young adults, in adolescents, and in children, most are benign. The breast concerns may be some type of breast development that's not symmetric, an infection, trauma, cyst formation, breast pain. The diagnosis that we usually may find are fibroadenomas or juvenile fibroadenomas, cysts, juvenile papillomatosis, mastitis, gynecomastia, or some type of hormonal change. Fibroadenomas really represent more than half of the breast lumps that we may see, the masses in young people, and that has to do with hormonal changes and the development of hormonal influence on the breast, and that does seem to exacerbate or increase the development of these fibroadenomas. Giant fibroadenomas are a large size. They typically may occur in young patients, and we will recommend surgery for those because of the large size and also the symptoms they may cause, such as breast pain. Cysts, fibrocystic changes, usually at the nipple. We may find some solitary benign cysts because of proliferation of this type of hormonal effect of fibrocystic change in young people. There may be an obstruction of a Montgomery gland that we may find in adolescent girls right in the retroareolar area too, or the periphery of the areola. For the ACR, American College of Radiology, has the most recent guidelines that have come out just May of this year, that all women should have a risk assessment by 25, and those that are eligible should pursue genetic testing really to further understand their risk. Now, if you are a high-risk patient 10 years prior to the age of diagnosis of your first-degree family member, like mother, sister, father, or brother, we may start screening you with mammography or start with MRI and do that yearly. So it's important for our young patients to understand their family history so we can guide them appropriately in their management. Now, before the age of 25, the last update that we had for average risk women for the American College of Radiology discussed having a risk assessment with every patient by the time they're 30, especially for minority women. Women of Jewish descent, or women that are Black. And then for average risk women, start at 40 every year, don't stop at 75, so there is no high limit, no upper age limit. If the woman is in relatively good health and is able to pursue the workup that may be necessary with needle biopsy, extra views, or even a surgical excision, then continue to be screened. Of course, there are risks. So some people talk about the risks of screening, but the benefits really outweigh the risks. And a discussion about the callback, the benign biopsy, or any anxiety for the patient also should be had with the patient. And sometimes the primary care physician plays a role here. Now, a young adult may come in with a nipple change, with skin change, with pain, with discharge from the nipple or a lump. Now, nipple changes, such as inversion, is where the nipple's inverted. It's not out, it's in. So it could be nipple retraction or inversion. 9 to 10% of women may have at least one inverted nipple for benign reason, such as prior surgery, an infection, fibrocystic disease. It's important to review the patient's medical history so you know if there's been surgery there or a trauma. So you know that that's not a new condition, but that's something that's been there for many years. This is a patient, and I know the right medial lateral oblique is not very good, but concentrated in the left breast is predominantly fatty pattern, but you see the skin at the nipple with inversion and a mass behind the nipple. So here we have a significant finding that's very different than the right. So we want to know if this is new, because this will be a sign of cancer if it's something new. But if it's old, it could be post-surgical, post-trauma, or other things. So flattened nipple also occurs. So as you see in the images are the most left that I'm showing you, or an inverted nipple. So sometimes when you examine a patient, you have to be aware, and the right questions to be asked are, how long has this been like this? Is this a new finding? Did you just notice it? Do you have any other symptoms associated with it? In this patient, her nipple retraction, which was only partial retraction, as you can see, this nipple is not completely inverted. There's partial changes. So there was a large mass in the upper outer quadrant that had kind of tails all the way to the nipple that was pulling that nipple in. Skin changes are evaluated. We may have a rash, there may be erythema, there may be swelling, dimpling. You can see here, we have two examples. There may be quite a bit of erythema, hot to touch or warm to touch. Most commonly, these will be some kind of dermatitis or an infection. But you have to think of inflammatory breast cancer when you see something like this. The top image, it is inflammatory breast cancer. The bottom is an infection. So mastitis, inflammation of the breast tissue, infection, it usually occurs in women that are producing milk, breastfeeding women, but it can occur at any age. And you're going to have to treat the patient, obviously, if you're the first person seeing her with her symptoms. This is an ultrasound of a 25-year-old. She has focal tenderness and swelling of the right breast. It's warm to touch. These symptoms and the edema that we see are suggestive of a mastitis. So you treat the patient and bring her back. In this case, this was an inflammatory breast cancer. Her doctor did treat her for an infection, but her breast was not warm to touch. She did have this significant edema, erythema, breast pain involving her breast. It is of a low incidence, about 2 to 6% of the cancers that we find in the breast, but it does account for 10% of breast cancer related deaths, so it's associated with a reduced long-term survival. Breast pain is very common. Women of any age will come in at different parts of their lives with a complaint of breast pain. It may be cyclical and diffuse, or focal and non-cyclical or one-sided. The causes of non-cyclical breast pain are many. Most are benign. Kind of the bottom of the list is an advanced breast cancer. Most breast cancer is silent, does not cause pain. But we have trauma, post-surgical changes, shingles, arthritis, an infection, fibrocystic disease. So how do we manage it? The management of pain, if you're under 30, we'll start with ultrasound. If you're 30 to 39, we may start with the diagnostic mammogram and ultrasound. Obviously over 40, we're gonna do a mammogram and an ultrasound. This is a 58-year-old, and she came in saying she has focal left breast pain that is intermittent. She had a mass in her left breast, and so that's not obviously the most common thing we find with pain. You can see how this is an irregular mass on the spot CC tomo and spot MLO tomo with calcifications that are associated. And here we perform an ultrasound after the mammogram revealed this abnormality, and we biopsied this mass under ultrasound, and you can see this irregular hypoechoic mass causing a lot of edema in the area and changes, and this was a high-grade invasive ductal carcinoma. How about nipple discharge? Well, it can be spontaneous or expressed. It can be any color really, milky, clear, straw color, green, or bloody. If it's in a young patient, we're thinking hormonal changes. If it's multiple ducts, it can be spontaneous or express. It can be bilateral. We're thinking benign, right? But if we have bloody or clear, it's a single duct, it's recent onset, typically it will be spontaneous. That is more suspicious, and we have to evaluate that further. Now, we perform a lot of ductography, which you may not, but we do. We cannulate the duct. Once we identify the duct with a suspicious discharge, we inject a small amount of non-ionic contrast, and then we take images. And we're very good at it. Of course, we don't just do this in a vacuum. We're going to evaluate this with the mammogram, the breast exam, the ultrasound slides of the discharge, and we may have to do a biopsy if we find an abnormality. We document electronically when we examine the patient and express for discharge, if it's multiple ducts, what color they are, and that's part of the patient's medical record. Most of the cases of pathologic discharge will be an intraductal papilloma, as many as almost half of the cases, as the literature shows us. However, as the patient gets older, the risk of malignancy increases with increasing age, and up to 21% of those with a pathologic discharge that undergo a biopsy may have a cancer. This is a normal ductogram. The patient had green color discharge for 2 months. She was 40. It was expressed. You can see that we cannulated the duct of the nipple. It's non-dilated, beautiful smaller ducts that it subdivides into. There are no filling defects. This is a normal ductogram. As opposed to this ductogram in a 65-year-old that had spontaneous clear discharge for a week. And you see this is a dilated duct. And then here we have filling defects in this dilated duct. So we biopsied this area under ultrasound. This was papilloma. This is a 50-year-old. She's had bloody discharge for 2 weeks. That's spontaneous. Multiple filling defects, right? Let me go back. I'm sorry, went too fast. Multiple filling defects all through this dilated ductal system, multiple non-filling. So this was ductal carcinoma in situ and also invasive cancer on biopsy. Palpable lumps, they need a full diagnostic evaluation. We all know benign lumps may be smooth, mobile, soft, malignant, maybe regular or immobile. That doesn't always work, right? Because in this case, I'm showing you on the top a spiculated, angry looking area that's cancer, but also the mass on the bottom that's high density and smooth is also cancer. But most of the lumps we're going to work up are benign. When we are working up a palpable lump in women over 40, we're going to do the mammogram. If she's had a mammogram and it's been, just a few months, then probably we may do just a picture or an image of that or a spot view of it. If it's within 3 to 6 months, we mark it with a radiopec marker. And we have lots of different paddles to use and lots of different views that you may use that are typical of your practice. So the workup of palpable lesions in women over 40 started with a mammogram and then an ultrasound, and we look whether it's a solid mass such as this one in a fibroadenoma or a cyst. This patient came in feeling lumps in her right and left breast. The one she felt on the right turned out to be a cyst, but the one on the left was this very irregular, very abnormal looking mass with echogenic rind, and this was an invasive ductal carcinoma. We do aspirate cysts if the patient comes in complaining of discomfort, and it's simple to do under ultrasound. We discard the fluid. Unless the fluid looks very suspect or infected, then we may send it to the lab. You see here a craniocaudal view on this patient with, you see a large mass, you see these cysts side by side on ultrasound and post-aspiration. So easy procedure, and the patient is very thankful if they have a lot of pain. Core biopsies we will do for calcifications or architectural distortion or masses, and of course it can replace a surgical excision. We do everything under tomosynthesis predominantly. This is our prone table, and we have several upright tables that we can utilize. Under ultrasound, you can see, your needle coming in as you're doing the biopsy, so you can see where you are live, and we always clip everything at the end and do post-biopsy clip images. We want to document where the clip is and make sure that's the area that we were interested in biopsying to start out with. So for women in their 30s, we follow our American College of Radiology appropriateness criteria. So if we'll go ahead and do an ultrasound and mammogram. If the physical exam is very suspicious, even if the mammogram is negative, we will pursue a biopsy. This is a 30-year-old that came in, and she has a lump in her right breast. She does have a family history of ovarian cancer in her mother and a grandmother with breast cancer. And so this goes to ultrasound pretty quickly after we do the mammogram, and this was juvenile papillomatosis on a needle biopsy. We frequently will recommend surgical excision on these. This is called Swiss cheese disease. It's benign usually. It may be found in young women that are 30 or less, and there is an association with breast cancer over time, so we do still recommend that it comes out. Now, if you have a young adult under 30, we'll target the palpable finding. We'll start with ultrasound and then go to mammography if we find something suspicious. Although studies have shown, such as the one by Dr. Loving in 2010, that for women under 30, if the mammogram and ultrasound are negative, the chances of being malignant are very low. But we will go ahead and use multimodality management to evaluate the patient, and the negative predictive value of those two is very high. This is a patient that's 26 with benign masses in her left breast. We do 6-month follow-up looking for stability, and then they're stable. We bring them back again, and then a year later to complete a 2-year follow-up. However, this is a 29-year-old that she has a family history of breast cancer and ovarian cancer. No one's had genetic testing. This mass is angry looking, there's calcifications in it, it's irregular in the upper outer quadrant, so she went to a mammogram, and you can see how many groupings of calcifications are in this left breast. Everywhere she's feeling something in the upper outer quadrant. So this patient obviously has invasive ductal carcinoma. This is another patient, 28, she had a left lump. We can see that this is very irregular looking on ultrasound with calcifications in it. So we quickly went to mammography. We saw architectural distortion and calcifications. Here is a magnification view of the calcifications. So obviously young people do get suspect findings too. So we did this biopsy under ultrasound. It was invasive ductal carcinoma. Of course, young people do get breast cancer, so women less than 40 may get breast cancer, so we don't want to ignore it. And these tumors may be aggressive and have high mortality rates. Women that are pregnant and lactating, we start with ultrasound, but if there's suspicious clinical findings, we're going to do imaging with mammography or tomosynthesis as indicated. And even though the mammogram may be less sensitive for these pregnant lactating women, together mammography and ultrasound are strong. This is a 32-year-old, she was 16 weeks pregnant. Her doctor thought it was a mastitis, what she was feeling. She had pain in a lump, but this was the mass that she was feeling in the subaerial area and an enlarged lymph node. And here is how she looks. There's marked skin thickening on the left with nipple inversion, maybe architectural distortion behind the nipple. So we biopsied both, and this was high-grade invasive ductal carcinoma. So we biopsied the mass and the lymph node. How about a male? Well, male with gynecomastia, it's a clinical finding. They don't need to necessarily go to any imaging, especially if on physical exam you feel something rubbery. But if you have a young man, more than 25 with a palpable mass on exam, you can perform mammography. You may start with ultrasound. This is a 26-year-old male, and he did have a family history of mother at age 38 with breast cancer and an aunt in her 50s. And then he has gynecomastia on both sides, more so on the left, and the ultrasound revealed the gynecomastia. So we discussed this with the patient. Our American College of Radiology tells us that if you have any determinate palpable mass in a young male on initial exam, well, you may not start with mammography, you may start with ultrasound, but you may do mammography also if you need to. This is gynecomastia in this 21-year-old male, and he had a lump, so you can see that it's quite a bit of development behind the nipple. And that's an abnormal development that could be unilateral, bilateral, and an imbalance of estrogen and testosterone. It's benign. It can also come from medications or illicit drugs that young people can take or older people. Up to 36% of younger adults may have gynecomastia. So in summary, I wanted to kind of go through a whirlwind of how to manage the diagnostic patient whether very young as a child, and then the women in their 20s and 30s and 40s, and also young males. And so you have to develop your protocols for these patients unique to the type of concern, and have procedures in place for every situation that will come through your facility. So multimodality approach is vital for an accurate, complete diagnosis. And this is my email, and thank you for your time.
Thank you, Dr. Stamatia, for this very informative lecture. And now we can open the floor for any questions for Dr. Stamatia. She's available now. Any questions? Yes, Dr. Noran, please.
Dr. Destounis, هو المفروض أبص فين عشان هي تشوفني؟ Which way should I look? Here? So she can see me? هي مش شايفانا? Okay. Okay. So I have a question.
I can hear you though.
You can hear me, okay. My question is about the focus in the BIRADS update, the BIRADS, the 6th edition. So a lot of us have been talking about this, that you've canceled the focus from the BIRADS. And actually for us in reporting, it was, we could either say this is background, part of the background, or it's likely a mass, or it's in the gray zone. So now you've canceled the gray zone for us. We would usually say for something that we are not sure, is it background uptake or is it a mass, we would say this is a focus and BIRADS 3 for follow-up. So now we don't have this option. So what's your comment about this?
So I just want to take a minute and say I just want to thank you, and I'm honored to be part of this meeting, and I'm so sorry to be remote. I know you couldn't hear me at the beginning of my BIRADS talk, so I just want to say how pleased I am to even be able to join you remotely. And I also want to say I'm sorry I don't have Dr. Wendy DiMartini here, who's the head of the MRI section, to defend the stand on this. But I think really the main driver was that people use focus in, without discrimination in many different scenarios. So it kind of became a catch-all term when people didn't know what to do with something. And really, we don't measure things typically that are less than 5 millimeters. And if something with our, high resolution contrast imaging that we have now with MRI, if you see something that looks significant, even if it's very small, and you can see margins, and it's a mass, go ahead and call it that. If there are multiple different areas that look very similar, obviously you probably will discount it, especially if you have prior MRI. We're not really asking you to change your practice. It's just really not use focus for every single thing we don't know what to do about. Whether it may turn out to be a BIRADS 2 or a 4, it's kind of a catch-all, so we want people to be able to really look at that area that enhances. And if you truly, it's new, if you have priors, call it a mass, call it non-mass enhancement. Go ahead and work it up and just not ignore it. Now, if it's something that you've seen before or in both breasts, obviously you can give that a BIRADS 3 NORAN. But I think focus was kind of in many cases used when people we didn't know what to do with something. And we do that with ultrasound also in the mammogram, and we just wanted people to commit to working something up.
Well, okay, thank you for explaining that. And we're sorry you couldn't be with us, and hopefully next year you can join us. Thank you.
Yes, and you look beautiful.
Thank you.
Any more questions to Dr. Destounis? Okay. We can now go to the next speaker, and this is Dr. Amira Hamid. She